Hello, everyone, and a warm welcome to all our participants joining us from different parts of the globe. Thank you very much for joining us in the third and final Lunch and Learn workshop on defining and measuring program success. This workshop is presented by the International Hospital Federation in collaboration with Charité University Hospital Berlin, Mayo Clinic, and Teledoc Health. Before we begin, some housekeeping reminders. First, the workshop will run for an hour and attendees will be on mute throughout the session. We also encourage you to send your questions through the Q&A function found at the bottom of your Zoom controls. Next, this session is being recorded and the link will be shared to you in a few days. And finally, you can find a link to download the session's worksheet in the chat box. And now, to kickstart the workshop, it is my pleasure to invite Ed Percy, who is the Vice President leading the Teledoc Health business for hospitals and health systems in Europe, the Middle East, and Africa. Ed, over to you, please.
Thank you, Rachel, for the introduction and for your help with the session. Depending on where you are in the IHF universe, good morning, good afternoon, or good evening, but hopefully not good night just yet. Myself, our esteemed panelists and the IHF are grateful for your participation today. This particular session is the last one in a series of 3 Lunch and Learns, where our friends from Charité and the Mayo Clinic will share with you their best practice approach to delivering a sustainable virtual care program. And joining me this week, and I'll introduce them more fully throughout the session, Dr. Jennifer Fang from a wintry Minnesota, Rochester, Minnesota, Ms. Beth Kriofsky from a wintry Minnesota as well. And to underline the international approach of telemedicine, Dr. Björn Weiss, normally of Charité Berlin, is joining us from Tashkent, Uzbekistan, where he's on a mission for the Charité and the Robert Koch Institute. The previous Lunch and Learn was focused on the opportunities that can be presented by a telehealth program, but also the challenges that can be encountered in such an initiative. Creating long-term value in our health systems is actually very difficult. And this final session will help you understand how to build a sustainable program that can continue to deliver value to your patients and your colleagues. I am certain you will find value in the deep experiences in transforming healthcare that will be shared with you today by our panel. And it's my absolute pleasure to introduce my friend, Ms. Beth Kriofsky, who's an assistant professor in healthcare administration and an operations manager supporting the Teleneonatology program at the Mayo Clinic in Rochester, Minnesota. Ms. Kriofsky has over 20 years of experience in healthcare, which includes clinical process experimentation, project management, product management, and systems innovation. I've said it before, but there is no one better to learn about the operationalization of a telemedicine program than Beth Kriofsky. Beth, over to you.
So our agenda today, I'm just going to run through what we have done to date. We're going to give a short overview of our programs at both Mayo Clinic and Charité. I'm going to recap some of the highlights from session 2. We're going to identify different ways to monitor your telehealth programs. And then we're also going to dive into how to apply change management strategies to facilitate both the implementation and the adoption that will lead to a sustainable program. We'll learn how to continuously improve and sustain using different change management approaches as we move forward. Next slide. So at Mayo Clinic, Teleneonatology is one of our many acute care telemedicine programs. This program allows neonatologists to be at the bedside of our critically ill neonates exactly when it's needed, whether or not they are born at our level 3 and level 4 NICUs, or if they're born out in our community sites. So we established our program in 2013. To date, we've done over 800 consults. We have 19 network sites with 2 states, soon to add another 4 sites in 3 states. We have 24/7 coverage models with our neonatologists covering neonatology. They are all board certified, and there's soon to be 11 of them. So our focus is delivering the right care at the right place at the right time. Next slide. So our colleagues from Charité have a program also developed out called ERIC.
Hello, good evening from Tashkent, where I'm currently located. So you see that the ERIC network is not our own program, but we are doing a lot of international programs, which I will only briefly touch today. So what is ERIC? ERIC is actually a network that connects intensive care units in the metropolitan area of Berlin and the state of Brandenburg in Germany. It's a network of ICUs, and the program was established in the context of a research project that started in 2018. We performed over 15,000 consults, and we are on the brink of publishing the results. So during the pandemic, we scaled from 11 to 28 network sites, and we are still operational in 2 state regions. It's definitely a regional program aiming at enhancing recovery after intensive care, so we want to avoid long-term impact for patients. We are using a 24/7, 365 staffing model. We're a round and response model. That means we have fixed rounding times with most of our sites, and we are responding whenever we are needed. We have 9 board-certified intensivists that are able to do the telemedical round, and the program is still operational also after the pandemic and serving the hospitals in our region.
Thank you, Björn. For those of you who don't know, Dr. Weiss is a consultant in critical care medicine at Charité of Berlin, Europe's top hospital, from where he currently coordinates that tele-ICU program at Charité, more than 40 remote sites in worldwide locations. Dr. Weiss has published extensively on critical medicine and is a frequent presenter at international conferences. Björn, thanks for joining us from Tashkent as well, and for leading such a landmark program, and good luck with the upcoming publication. At this point, we think it's worthwhile reviewing quickly the first session's takeaways in order to place this third session in context. The second session was oriented to understanding the key considerations for program implementation, where the following key takeaways were described. Identifying and engaging stakeholders early in the process is fundamental to sustaining the program. Designing a workflow to meet defined performance goals is crucial. And before your program launches, running a small pilot is a great suggestion. If you're going to fail, fail fast and learn the lessons. Start small and then scale. And use implementation strategies that address training, feedback, and refinement. And a comprehensive summary of the session can be found on the IHF website with a full recording of the session for your consideration. I'm pleased now to introduce Dr. Jennifer Fang of the Mayo Clinic. Dr. Fang is an assistant professor of pediatrics and serves as the medical director of Mayo Clinic's Teleneonatology program, working closely with Ms. Kriowski. Dr. Fang has published extensively on teleneonatology and is frequently invited to share her expertise nationally and internationally. Dr. Fang, over to you.
So much, Ed. And So we're going to move on then into our current content for this session. And we're going to lead off with thinking about, as you've designed and implemented your acute care telemedicine program, thinking about how you are going to measure the value that your program brings. And those of you who were able to attend the first session or watch the recording of that, this is really going to link back pretty strongly with what we talked about there. And so as Beth, Bjorn, and Ed, and Allie, and I were talking about the content for this session, I think, Ed made this comment, like, yeah, we have to remind them to always start with the end in mind. And I think that is so true. And so we just wanted to include that here. You're designing and implementing a program with a purpose. You identified a gap in care for your patients, for their families, and you have a goal you want to achieve, whether it's improving patient outcomes or improving access to care, whatever it might be. This is where we're going to think about how do you measure that value so you can communicate it to multiple stakeholders. Now, I guess being trained and working at Mayo, whenever anyone says value, my mind immediately goes to the value equation. What does value mean? How can we improve or increase the value of care we're providing? And there's a few different ways we can do that. It may be that you're looking to improve the quality of care, like Dr. Weiss did, looking at quality indicators in an ICU setting. You may be looking to enhance patient safety through, supporting perhaps lesser experienced staff in smaller hospitals like we do with neonatology. You may be aimed at improving the patient experience, making sure that care delivery fits into how they need to access care. Or you may increase value by reducing the costs associated with the care that's received. So it's really important, again, with your program, you identify your metrics, your value metrics that you can measure and use to evaluate your program. And really with the goal being to be able to do this in real time. It's also very helpful to have identified these metrics because while you may have a project that has a 6-month or 12-month timeline, I think all of us have this goal of creating a program, though, that continues on long term. So knowing what your metrics are going to allow you to evaluate your program's impact, when you're perhaps halfway or 3/4 of a way through your project. And you can take that data and demonstrate the impact you've had, whether, again, it's, look at these patients, their resuscitation is adhering more towards the standard of care than it was when we didn't have telemedicine, or our patients are experiencing, fewer, let's say, healthcare associated infections. If you can take that data from your pre-identified metrics, you can use that then to really achieve long-term program sustainability by taking that demonstrated value and securing the resources and the staff that you need to have your program endure. Next slide, please. So I did want to take a few minutes just to talk about a little bit more in detail about methods for measuring the value of your program. And when I think many of us think about outcomes, we think about value can be measured in how your process is performing, as demonstrated through process metrics. And we also think about other metrics that might be outcome metrics. So because you have designed a new process and basically integrated that into a pre-existing care model, you want to make sure that your process is performing as designed and reaching your target performance metrics. So examples for us would be, again, we're an acute care telemedicine program. So when people call saying they need us, we need to make sure we have a very quick response. So VATH measures our time to phone. How quickly are we getting on the phone with that referring provider? We also monitor time to video. The goal is to be on video, ideally within 5 minutes. And so these are metrics that we follow and we monitor to ensure that our program is meeting the needs of the staff and the patients we're trying to support. So thinking specifically about what process metrics you can monitor. And then importantly as well, your outcome metrics. So some of this can be, I would say, a bit more simple, straightforward, and easier to measure prospectively. So it may simply be about access. How many sites are you serving? How many consults have you performed? What types of patients are getting consulted as a part of your program? But you will want to dig deeper into very meaningful patient or family-centered outcomes. And so sometimes you can do that prospectively. Sometimes if it's more time-intensive, you may have to consider doing that retrospectively. But this is where you're going to be thinking about, how do I measure quality? How do I measure safety? And so I think both Beth and I, as well as Dr. Weiss, have measured our programs with various different methods. Admittedly, when we started, we were focused more on QI, that we established this program and we used some quality improvement methodologies to say, okay, I have kind of a bundle of metrics that I want each consult to meet with respect to time to video, technology performance, teamwork and communication. And for each consult, I'm going to evaluate that bundle and see if it meets the bundle or not. And if not, we're going to learn why not. And we're going to figure out how we make improvements to make sure the program's performing. We then have transitioned to more research methodologies through both retrospective cohort studies and prospective pilot studies. And Dr. Weiss can speak more to this about doing larger scale kind of forward-looking randomized studies as well to measure the impact of your program. When we think about patient experience, as well as family experience and honestly staff experience, I think in this situation, strategies like surveys, individual interviews, structured focus groups can be very helpful. We took this approach within the first, I think it was the first year or so of our program, where we surveyed, but also did a mixed method study that used focus group interviews with our staff at our referring hospitals to really understand what's working with the program, what's not, what's critical to success, and what can be real true barriers. And keeping in mind, you're going to want to get this from multiple perspectives if possible: patients and families, your perhaps, let's say, referring providers in your originating site, and as well as the people providing consults through your program, so the staff at your distant site. And then one last tip that I would love to share with you that Beth and I have been working on is just thinking about within your organization, are there any existing resources that you can utilize and tap into? If it's anything within, if you have an electronic health record, are there any ways to pull data from that or have automatic reports generated? Are there existing resources within your information technology or perhaps a virtual care department that you can use for your program? For our program, truthfully, it started when I was a fellow in training, which actually created a great opportunity because as a fellow, I had protected time for research and I poured all of that time and effort into program development. So if you happen to have learners or trainees at your site who have some time for kind of academic pursuits, you can try to take advantage of that as well. All right, next slide. So here's where we wanted to provide some examples about how our teleneonatology program here at Mayo Clinic and then Dr. Weiss's program in Charité have really looked into measuring value. And for this slide, we actually borrowed from the WHO's telemedicine implementation guide, which can be a really nice resource. And they kind of categorize their metrics into these 5 categories. And so we're going to share our information kind of with that framework from the WHO. So when we think about our program here at Mayo Clinic, our teleneonatology program, as Beth mentioned, our reach is currently to 19 hospitals within 2 states, and we're typically consulted in about 2 to 3% of live births at these hospitals. We've measured the effectiveness of our program through different studies. One demonstrated that presence of the neonatologist via telemedicine does improve the quality of neonatal resuscitation. We also did an economic modeling study that demonstrated that this program, compared to usual care, is actually cost saving. When we think about adoption, 100% of the hospitals that have family birth centers within our program use the service and have used it within the last 12 months. And we may have mentioned in a previous session, but we do have surveys we send out to our users after each consult. And that's really to look at how satisfied are people with the service. And we've been able to achieve and maintain very high levels of user satisfaction. The process metrics I mentioned earlier, we look at those to look at the effectiveness of our implementation and program performance. And you can see here our median time to phone is just over 2 minutes and our median time to video is under 5 minutes. Through the vendor, we also get reports on how our uptime is for the products we use, and we have a 99% product availability. And then lastly, maintenance. Again, I think through the great efforts by Beth and others on our team, all sites have continued the service from when they started. They continue to receive the service. We do have 3 sites, three external contracts that have been executed. 2 of those contracts have been up and running for years. And as Beth mentioned, we have 4 new sites coming on here next year. And part of maintenance, which we'll talk about more as well later in the session, is thinking about how you financially sustain your program. And for us, that's largely through external contracts, as well as payment for consultations within the Mayo Clinic enterprise, where we get reimbursed by both our government and non-government insurances. So with that, I'm going to pass it over to Bjorn to talk about what he's done with Charité.
Thank you very much, Jen. Yes. Actually, I can echo what you said, and I really want to repeat it for our participants because it's so important. You have to think about the end before the program is finished, because measuring quality and measuring effectiveness is definitely paramount, because there will be the point when the money is running out, when your program comes to an end, to a funding end, or to a predefined date where the program actually stops. And then you really need to have an idea how effective the program was and how you come into this phase of maintenance or even scaling it. So you have to target metrics and you have to think about data collection. And I highly encourage everyone to prospectively collect data, because this data is usually of higher quality. And so let's take a look at our network and how we did it. So I already told you that we had 28 hospitals in the area, and we cover 70% of the emergency hospitals in that area, actually. So we have quite a holistic approach. When we did the ERIC program, though, this trial, it was only 11 hospital companies that have actually been signed into it, which is still quite a large study, but of course not comprehensive. So our effectiveness measure was the improvement of quality of care, and we measured that in quality indicators. So we have German quality indicators 10 for intensive care, which rely on international and national guideline recommendations. So it's, if you want, so common sense. And we wanted to have the continuous improvement of care by telemedicine. So it is important to distinguish between programs that are just digitalizing a part of care, meaning like, for example, filling a gap, reach out to remote areas, or a program that is actually aiming, and I think the Mayo program is, and our program is as well, to really not only digitalize a part of care, but really increase the quality of care. So the scientific evaluation in our case was done in a context of a clinical trial. So the method we used is a step wedge cluster randomized controlled trial, where actually we had predefined transition points where hospitals were added to the telemedical intervention. And that was evaluated, and you can read that very soon in ICM. The adoption, 100% of the hospital use the telemedicine, but in the maintenance phase, only 50% do regularly scheduled visits. There's also a significant part of the hospitals that decided to only do an on-demand rounding, which we do not explicitly encourage, but it also shows that in the adoption process, you need some kind of flexibility. So 99% availability was there when it comes to technical availability of the program. So the technology we are using is functioning extremely well, and the availability, of course, and the routine of the physicians increases when regular visits are performed. So really, I encourage every program to do regular visits. Regarding maintenance, we have a positive recommendation from the Federal Joint Committee for the program, and there is continuation planned. All sites remained in the program. In contrast, we even scaled the program during the pandemics. But still, it is a lot to think about and a lot to take into consideration when it comes to this point of the evaluation. And I also would like to add that there usually is a phase between the end of the data collection, so if you want, so your telemedicine program, and the time point where your data is made available via reports, publications, etc. So this time might be, if you're a quick 6 months, but it might also be 18 months. And you should also consider the financing model, for example, to cover this time.
Thank you very much, Björn, for for that excellent overview, and Jennifer as well for reflecting so profoundly on how you measure effectiveness of a program and how you build sustainability. I love the description of value of care as being a function of quality, safety, the experience of care, and of course inversely proportional to cost. But so few people consider the experience of care. And really, I think experience of care is not just for patients and families, but it's also the experience of care from the provider perspective, the doctors, the nurses, the specialists who are involved in that activity as well. So audience, it's now over to you for some homework. So reflecting on the presentations from the panel members today and the situations within your own unique health systems, I invite you to think about and document how you would measure performance of your telemedicine program, and what metrics will you use to monitor and evaluate your acute care telemedicine program. You can download the WHO Telemedicine Implementation Guide via the link there that Jennifer referred to. That guides pretty much everybody in how to build telemedicine, but thinking specifically about some of those metrics and how you're going to measure them, the reach or scope of the program. Effectiveness is multi-dimensional. How do you measure that? And of course, that depends on the clinical setting. So again, working with your colleagues who are actually providing that service to determine what's most effective. Adoption of the program across a landscape. Sometimes these telemedicine programs are geographically significant in scale. Mayo Clinic, 19 hospitals, a 2-state system, Charité delivering healthcare in other countries over telemedicine. Thinking about the implementation and how you're going to instrument the process of implementation in order to be able to collect metrics. Jennifer and Beth talked about time to video being really important, time to picking up a call, but by instrumenting the process itself and identifying these measurable segments in the service activation and the service delivery. It's a really interesting way to ensure that you can continually monitor and improve the program, and we'll reflect on that later. And then thinking also about maintenance. Often we build telemedicine programs without really thinking, well, what happens at the end of the funding cycle that we've got to do this? And so starting with the end in mind is really about thinking, how do we build a funded and sustainable and continuously improving telemedicine program? So that's your homework. We're not expecting you to do it now. We have our panelists with so much experience to share with you. And so it's now my turn to hand over to Beth Kriofsky of the Mayo Clinic to reflect on how to manage change most effectively. Beth, please.
Thank you. And So change management is something that occurs not only within the project, but ongoing. Today is a testament of that. I am in one of our sites, assisting with training and introducing the program to new staff here in one of our sites. So change management really does address the people side of change. We can design the best process. We can have the best technology available to support that process. But if we don't enable people to engage in what we're implementing and adopt the telemedicine service that we're building, the program will not be successful long term. It can be helpful to use a framework for change management. We like the ADKAR model at Mayo Clinic, the ability to build awareness, desire, knowledge, ability, and reinforce our programs. And this goes not only, or can be applied not only to the project itself, but the ongoing maintenance and sustainability of the program once it's operationalized. But this allows us to use a model that can guide individuals through specific change. And that goes for addressing barriers that may come up 5-10 years down the road when you need to make adjustments to your workflows. Next slide. So change management is critical for program success in multiple ways. And we've put this bubble diagram up on the right to identify where all of the intersects are between the different stakeholders that you need to engage with. And you need to take each group of individuals through different sections of ADKAR. For example, our distant site healthcare providers, they need to be aware of the program. They may actually help you develop why there's a need for change. They might help you identify what's the gap that they're facing in clinical care at the beginning of your defining what the program phase is. If there's a desire to participate in the change, originating health system sites, your distant site professionals, if they've had a negative experience with patient care at some point, they will have a desire to change and to make adjustments that will improve the access to the specialties that they have and to the care that they can deliver to their patients. All of this, we also, you need the ability and to know how to change. So as I mentioned, I'm out in one of our health system sites today training. Our staff don't always interact with these programs. They're doing their day-to-day patient care assignments that are here on site. But when they need us quickly. So how do they know when to use us, and how do they know how to adjust their workflows to incorporate our telemedicine programs? And the ability to implement the required skills and behaviors, again, that goes back to training and knowledge of how the programs work and function. And then our reinforcement to sustain the change, it comes with ongoing maintenance. Dr. Feng mentioned how we measure and how we identify what we're going to measure long-term. If you're constantly collecting data and showing improvements, either small improvements or large improvements, or identifying where there might be a new gap in your process, you can adjust and then reinforce how we're going to make changes within the program itself. Next slide. So here's how we approached ADKAR and applied it to our Mayo Clinic Teleneonatology program. We created awareness first and foremost by highlighting all of the changes that were happening nationally with rural communities and their access to inpatient obstetrics and access to neonatal medicine. There were a lot of personal experiences that came forward from not only our neonatologists, but also our physicians out in our rural communities. So we took those and we made a story out of it, and we created awareness not only with our care teams, but with our leadership teams and our IT teams as well. We looked at some of these patient outcomes, and we looked at some of the experiences that people had had, and we used that to create a desire to implement and change the way we were practicing and the way we were accessing neonatal medicine within our system, and explore the ability for us to use telemedicine. The knowledge of how we were going to design, implement, and sustain the program came from interdisciplinary collaboration. We partnered with actually with the site that I'm at today to look at what were their needs, what are the needs of the nursing teams and the physicians in the site that will be receiving the care, and then how do we create user training and education that will meet their needs, but also how do we make sure that we can build the need to change into the user training and education for our admissions and transfer center staff that will be taking the telemedicine activation phone calls, and the user education and training for our physicians, the neonatologists on the other end, so that everyone has a knowledge of how to support the program, how to react, and how to care for patients in that virtual setting. We have the ability to simulate prior to service go live. When you have the ability to try things in a safe environment, people become comfortable, their knowledge builds, their desire to activate the service builds. We can make iterative improvements during these simulations. So if we have a simulation prior to go live and something goes wrong, we can address it before we turn the service on. And then monitoring our system performance and seeking feedback. We're consistently asking for feedback, reaching out to our nurse managers. If there's a potential that something didn't go quite as planned, we're working with that team to figure out how we can correct the problem, how we can improve an area that might have been a little bit challenging. But we're consistently using education, simulation, and communication to build and further develop the ability to manage and sustain our program. And then reinforcement. The survey comments that come in that say, Dr. Fang was a large help for me today. She assisted me with the transport team, or she assisted me with how to place an umbilical cord line. Those things we take and we provide it back to our neonatologists. In a similar fashion, if something went very, very well, if I hear comments or praise given regarding a site, or if they have a new care team member that did something very well, we're sending that information back to the nurse managers or to the physician leads at that site so that they can share it with their teams as well. Positive reinforcement helps support change, and it helps support the program. We also look for opportunities to publish, present, and lead as we're developing out and as we're taking on new research and quality improvement initiatives within our program of teleneonatology.
Back to me. Thank you, Beth, for sharing your experiences and insights in the ADCAR model. It's a little bit more homework for our audience. So reflecting on what you've heard from our panel, particularly Beth, and thinking about how to engage with parties across your organization to ensure change management is driven most effectively. How will you create awareness? Invariably, there's lots of ways of doing this, but a sound communications plan and strategy is invariably a major ingredient to a successful outcome. How do you build desire? Desire often comes from an understanding of the problem and that it can be resolved. How do you share knowledge about the program? How do you build ability? And simulation is a much underused capability in healthcare. And again, an example that we can learn something from the airline industry, where simulation is a routine part of continuous improvement for airline crews. And then finally, reinforcement. How do you reinforce what went well? How do you investigate and resolve what maybe didn't go well? And as a a good friend of mine who's a 3-star general in the US military would say, everyone loves a gold star. So when a team member has done something well, it's a great opportunity to share that and reflect in a really excellent performance. So thank you for that, Beth. Very, very useful. I'm now going to invite Dr. Fang as we turn our thoughts to establishing the sustainability of a telemedicine program. And there's no one knows more about this than our panelists. And Dr. Fang, over to you, please.
Great. Thank you, Ed and Rachel. Oh, perfect. So as we were thinking about, our kind of final thoughts we wanted to leave with all of you in this final session in our webinar series, we really wanted to make sure we addressed program sustainability. With all the effort and time you're investing in designing and implementing your programs, we want to make sure that that program can be sustained over the long term so you can continue to serve your patients and their families. And so as we were reflecting on this, there were a couple things that really came to the top. The first was what's been already mentioned a couple of times, which is the real need to focus on continuous improvement. Despite how much thoughtfulness you will put into program design, how many resources you will use to successfully implement, I can guarantee it will not be perfect the first time you implement. There are going to be missteps. There's going to be things that seemed like they should be right and function well, but didn't. And so knowing that, just expect that and be prepared to address it through your continuous improvement approach, I think is really important. And again, this is where having your program performance metrics serves you so well. You're going to see whether or not you're hitting your metrics. If you're having a difficult time, getting onto phone, getting onto video, despite what you thought was an appropriately designed process, okay, well, you're not meeting that. And then you have to dig in, figure out the root causes for why you're not meeting your program goals, and then make changes, make improvements. And we've seen this in our own program. Like, why are some sites really heavily using our program and other sites not? And I think the other thing that this does that Beth, I think, really alluded to is that when you're so invested in continuous improvement, it really creates a tone and a culture within your program and everyone who interacts with your program that you are very committed to what you're doing with telemedicine and the patients and staff you're serving, and you are dedicated to make sure that the program is high performing and effective for them. So continuous improvement was one. And then the second, which again, you've heard us hint at a couple of times, is you do need to be thinking about how to make your program financially sustainable. Thinking beyond your initial 6-month, 12-month project, that how are you going to receive compensation for the work being done in your program, whether this is through, for us, some of it's external contracting and payments that come in through that, or making sure that when we do our consultations, we're adequately documenting so that our people can code that interaction appropriately and bill insurance so we can see reimbursement. So really thinking now it is not too early, let's just say, to start thinking about it right now. And there's different approaches. If your organization already has other telemedicine services, there can be opportunities to bundle like services together. So thinking about different strategies within your organization, and you may need to think beyond that. As you're building and designing and creating these programs, you will be viewed as an expert. People will come to you, and using that experience and influence you have to advocate to make sure that these telemedicine services are being appropriately paid and reimbursed. Next slide, please. So I'll share our perspective and then I'll pass it over to Bjorn. But for us at Mayo Clinic, and we think about our teleneonatology program, already mentioned, we are actively, prospectively monitoring our program performance. Beth sends out electronic surveys after each consult so we can get feedback. And then we use that data to figure out what changes we need to make. And I will say, and Beth will attest to this, we struggle the most with having reliable, fast service activation. And it's because there's so many human factors. The staff in our birth hospitals need to activate accurately, call the right number, use words that the call center nurse recognizes to mean a neonatal telemedicine consult. And that can be challenging with staff turnover. The nurses in our call center, they receive thousands of calls a day. So they need to know that when this one comes in for a newborn who needs a video consult, here is the action I take. Moving on to financial model, I already mentioned this. Really for us, it's two revenue sources that help sustain our program. It's the external contracts, and then it's also the payment or reimbursement we get for the consults that we provide from insurances. I will also just take one moment to say we are at an organization that has invested in a digital health strategy, and so we do benefit from the organizational investment in that, so that if we're implementing at a new site, as we will be doing early here this next year, we can use those implementation resources, use our credentialing resources, all of these other resources, which is really helpful. So with that, I'll pass it over to you, Bjorn.
Thank you very much, Jen. Again, I can only tell you that this is really important to look at continuous improvement processes, as said. So we are struggling with the digital advancements, because what you really want in your program is to have not more work, but less work. So you need to connect your telehealth program, which is per definition something between two hospitals. You need to connect the EHRs, and you make sure that this is safe in terms of GDPR. So you need to organize referrals, and you need to identify all the different interfaces to your organization's work, and to make sure that the program is embedded in the workflows, because you will identify and will be surprised about the identification of interfaces that you did not think about. For us, for example, it's the organization of secondary referrals to Charité, which sometimes happen in the region, that we do a teleconsult that results in the recommendation of a secondary referral to our center. And having this work process, and again, having the human factor involved in it, is extremely important. In the European Union, GDPR risk assessments have a really high priority, and this is also something which you have to embed into your continuous improvement process, as well, of course, as the legal aspects. So I really, really recommend that besides the clinical continuous improvement process, you also have an organizational continuous improvement process, and you do not lose the attachment to your organization. Regarding reimbursement models and a sustainable financial model, we have a statutory public health insurance in Germany. So for us, the process of reimbursement does not work with billing, but it works with money paid by the public health insurances in a DRG system. We're now looking for center-based reimbursement versus an individual reimbursement. Both is generally possible. If you have case-based reimbursement, you also have the challenge of provision, because you need to have a system that actually is available also during non-service hours, because the activation of service, and that is also what Dr. Fang mentioned, is extremely important, and you need people in the originating side that are available 24/7 to deliver this service, although those people are not earning money, but just have to be there for the provision of care. So these things are like, it's like a little bit food for thought. So you can take them and you can think what adapts to your system. And I hope that this example also helps you to get a sustainable telemedicine program running. Thank you.
Thank you very much, Bjorn and Jennifer. So once again, having heard from our esteemed panel on the topic of measuring performance and building sustainability, to once again turn and view the audience to consolidate this knowledge for your own telemedicine programs. Do you have the infrastructure in place to continuously monitor and improve your telemedicine program? Identifying institutional resources like a digital health team or an electronic medical record team that may be available to you and trying to automate monitoring plans when possible. Instrument the process to collect those important waymarks that will help you understand how effective the program is. And then what is the business model for your acute care telemedicine program after the initial phase? Thinking about the long-term financial models before any short-term project or grant funds expire. The key takeaways from this last and final session is really develop methods for monitoring and evaluating the reach, effectiveness, adoption, implementation, and maintenance of your telemedicine program will allow you to communicate its value to multiple stakeholders, and communicating that value throughout the life of the program is crucial. The clinicians that you'll be working with are very busy people, and so constantly reinforcing the value of the program is really important. Use change management strategies to facilitate the implementation and adoption of your program, the ADCAR approach that Beth spoke about. And the success and sustainability of your program will require a continuous improvement model and a viable long-term financial strategy. So it's now my pleasure to invite my friends from Mayo Clinic and Charité to join us for a Q&A session. And my first question, I'm going to ask Jen and Björn. For measuring value, is there a particular stakeholder group which carries greater weighting or influence than others? In other words, is the most important opinion that of a specific clinical group or of the patients and their families, for example?
All right, I'll go first, maybe Bjorn, then I'll pass it to you. So I think it's such a great question, and I will just provide a quick context, right? So our program is a neonatologist providing a consult to a pediatrician or family physician, obviously the newborn's there. But I think for our program, and it goes back to, our first session, I think it was really about, we needed to make sure the program we were implementing addressed a real problem that people experienced. And that being, the provider at the birth hospital who's perhaps struggling to resuscitate a really sick baby, obviously the baby who was born very ill, and then the neonatologists who feel they can't adequately do that over the phone. And so I think from my perspective, our program would not have gotten off the ground if we did not have buy-in from the providers in the birth hospital, so the originating site, the neonatologists who also felt the problem and were willing to engage in the solution. And then, our patients and families were kind of benefited because of the buy-in. So for us, I think our program was able to start and succeed because of the belief that both physician groups had, both in the originating and distant site. And then that pulled everyone else along because we could communicate a compelling story and a compelling need to the other stakeholders that we needed to get on board. All right, Bjorn, what do you think?
Yeah, it's actually very wise what you said, and it's a very good question, Ed. But I think for me, the most important stakeholders are always the patients we are caring for, right? I mean, we don't have a self-esteem, we have a clear task. We need to save our patients and we need to take care of their outcomes. So this is the primary thing we are standing for. And it would be even a recommendation from me to say that you should always have patient outcomes involved in your telemedical program. You can do surveys, you can do, satisfaction interviews, and you can check how happy the staff is with your program. But in the end, it is about care, and it is about effectiveness, and it's about what is your program really doing. That can be very often in telemedical programs, it is not about the quality of care. This is a secondary outcome, but the primary thing is access to care. When I look, for example, at here in Central Asia at our programs or our other international programs, we very often discuss about equity, about excess of care. And it is really difficult to measure that because the control group is lacking. You cannot prospectively have a control group. But when you start such a program, be aware that you need to find a good outcome that can be a quantitative one. It can also be a qualitative one that is measuring how your program affects patients. I think it's very often the case that this is not prioritized, or that cannot be prioritized high enough, actually. So I would definitely say that. Aside from that, it's also important, of course, to look at the workforce, to look at the multidisciplinary workforce. Do not forget that it's not only about the physicians, but it's also about the nurses and the allied healthcare professionals that often take a very important always take a very important part in the care process, and they should also play an important part in the digital care process. So do not leave out stakeholders that you may not think of in the first instance. That's the second thing. And the third thing is, I also would even go so far and say, look at the program's impact from a public health point of view. So go from an institutional level, from a clinical level, go up to more like a level that also asks for public health questions. So how does your program impact the overall population health? That's something that we do here in Uzbekistan, for example.
Thanks very much, Björn. I think, Jennifer, you just had a quick
Just one brief. I think being patient-centered is so important. And I just wanted to say, if you can find a patient or family voice, they can really advocate. I mean, it does take a patient or family the ability to recognize the gap, like, oh, wait, why am I not having a neonatologist here? Or why is there not a special adult critical care doctor here? But if they can have a strong voice and they recognize what they need, it is very compelling, and those patient stories are very powerful.
Great, thank you. Patients at the center of everything, right? One of the Mayo shields. Today, we've had the opportunity to learn from our esteemed panel on measuring value and building sustainability in telemedicine programs. This is the concluding webinar of our series on designing and implementing sustainable acute care telehealth programs. A recording of this workshop will be made available, and all those who attended will receive a notification once the video is live. And on behalf of the IHF, on behalf of our fantastic panelists, and on Teledoc Health, thank you for joining us all today, wherever you are in the IHF world. And if you celebrate the festive season that's coming up, then best wishes to you all. Take care, everyone, and bye-bye.